for cancer survivorship. Oh, I have to consent to be recorded now? Okay.
Oh, I didn't know that.
Yes, I'm consenting to be recorded now. So we are recording this session. This will eventually show up on the Smilow YouTube page with the previous 2 sessions that we did, our intro session and then our nuts and bolts session that we did 2 weeks ago. Today we're going to be discussing cancer-related fatigue and how what we all bring to the table as far as how we look at cancer-related fatigue through our scope of practice and how we put it together, making sure that we've got the patient at the center of our care. So Jevin, if you want to go ahead and pull up today's PowerPoint, that would be great. So again, this is our team, and this is our rundown for today. And typically with these echo sessions, at least what we were taught when we went out for training out in New Mexico, they want us to do obviously an intro, and a lot of times they want us to lead with a didactic portion and then go into a case study. But we're going to flip-flop that today because we want to make sure that we always want to put the patient first. So we're going to do our case study first because we want to make sure that we have enough time to go over that and use that to generate questions and leading into the didactic, and also to give you guys an idea of what the case study looks like. Because moving forward for the next 3 sessions after today, we want you guys to think about a particular patient that you may have encountered, and we want you to bring that patient forward so that we can talk about, what were your successes, what were some of your challenges, and what we can do to kind of help moving forward, with this multidisciplinary approach to survivorship care. And then we'll wrap up today with some extra time for questions, and then we will we'll adjourn and we'll give you some announcements heading into our next session, which will be 2 weeks from today. We do this because we love it. We're not going to be millionaires doing this, so we do it for the love of the program.
And so bear with me when we switch screens.
So as Jevin pulls up our case study, I'll tell you briefly that this patient that we're going to be discussing, we've met several times now. Last week when we were talking about kind of our nuts and bolts of how our clinic operates, we typically will see a patient for an initial assessment and then a follow-up visit anywhere from 8, 10, 12 weeks later, just to see how our talks went, and how they're doing with the recommendations that we gave them at that first visit. And we don't generally have a follow-up visit after that. This individual that we're going to talk about right now, she has actually come back to us a 3rd time, and if I understood correctly, she is actually on our schedule again for a 4th visit in July. And so, because I always make, especially if I'm the last one to go on the team, I will always make sure that I tell the person that, survivorship is for the rest of your life. And so, we're not going to limit you just to 2 visits. So our doors are always open. So whenever you want to come back in for a check-in or a tune-up, we're always here for you. So with that, I'm going to have Jevin set the stage here and go into a little bit of background about who our person is. And then we're all going to talk about what we did, what we brought to the table for this patient when she came to our clinic.
Thanks, Scott. Oh, I'm echoing here. Give me 1 second. Nope. Just going to stop the share for a second. I'm going to mute everyone here for a quick moment. All right. Any more echo? I don't hear it anymore. Okay. Sorry about that. Okay. So today we're going to be talking about Miss S. And as Scott said, she has come back 3 times and will be coming back a 4th time soon. She's a 46-year-old. She was diagnosed with stage 1 papillary thyroid carcinoma. And she was diagnosed 9 months prior to when she presented to us in survivorship clinic. And we chose this case because she was a good multidisciplinary example of someone who has cancer-related fatigue and who needed counseling for that. You know, thyroid cancer patients share the same survivorship concerns as people with other cancer diagnoses too, although they're not one of the more common cancer diagnoses we see. They still make up a good population in our clinic specifically. And these issues that she had serve as a good example for a theme that our team has identified, which is that cancer may often be the least of someone's problems. Since we're presenting, we didn't have any challenges or anything we wish we knew since she came to see us in clinic as a survivorship team. Her two primary concerns were how to adjust her diet now that she didn't have a thyroid. And she rated that as bad as possible, 6 out of 6, as well as absolute exhaustion. Again, going with our theme for today, which is cancer-related fatigue. Before each visit, and then again after each visit, we also provide a distress thermometer to get an idea of what the person's distress is coming into the visit, and then how they're leaving the visit with that level of distress. So coming in, she was at a 7, and then leaving that day, she reduced down to a 2, and this is out of 10. She found nutrition to be the most helpful, which matched one of her primary concerns. At the second visit, she came in at a 6, and she left at a 2, finding that physical therapy was the most helpful, again, matching one of her primary concerns as well. But by that point, as you'll hear from us, she made a lot of changes which had helped her from the first visit. And just going down to some of her history, again, she had stage 1 papillary thyroid carcinoma with 1 out of 12 lymph nodes involved. She had a total thyroidectomy in January of 2019 and a right central neck lymph node dissection as well. And that resulted in a visible scar with some pain and tightness that she complained of at the appointment as well. She did not get radioactive iodine, and then she was on thyroid replacement hormone with levothyroxine now that she didn't have a thyroid. And then we have some lifestyle information here at the bottom as well. The takeaway that I want to give before I get into the rest of her case is that we do provide this case presentation form for everyone to use if you want to, but it's more of a template and a guide. If you want to just bring up a case during these sessions, feel free to when we're discussing, and it doesn't have to be anything formal. If you want to use this, I'm happy to go through it with you, happy to do a mock presentation. But this is what it looks like for your use at your convenience. And just to go into a little bit about my visit with Miss S, again, her primary concerns were with fatigue, and part of that was concern she had about her thyroid levels, her thyroid stimulating hormone, her thyroid globulin, and so she was concerned that those were out of range. And at my visit, we reviewed the national guidelines per the National Comprehensive Cancer Network, or NCCN guidelines. And I brought those to her attention, and we reviewed that she was, in fact, within expected range that we wanted her to be in. And she was being followed by endocrinology as well. However, she had just started on our levothyroxine, and her dose had fluctuated a little bit. And I talked to her about how that can take time for some of her symptoms to resolve as a result of that dose fluctuation for her body to acclimate to that dose. And so that was a major component for her, and that, again, can be affecting her fatigue that she's having as she adjusts to the levothyroxine. So I'm gonna pass it along next to Angela, who can talk a little bit about her visit.
Okay, thanks, Jevin. Hi, everybody. Again, I'm Angela Kerala, the clinical social worker on the team, and I have to apologize in advance. In the afternoons, I have problems with my Zoom, so hopefully I don't get disconnected while I'm talking today. But anyway, when I met with Miss S, she's a single adult. She resides alone. She has no children. She's in the entertainment business. And for her distress thermometer, as I've mentioned previously, I really paid close attention to the distress thermometer since my time is limited with patients. That's what I use as my framework to try to utilize my time with them the best way that I can. And so some of the areas on distress that she marked, she rated herself a 7, and she marked finances, she marked work, sleep issues, anxiety, depression, fears, nervousness, sadness. So those were the areas that I addressed with her. We also found that, she reported this kind of extreme exhaustion when she came to our clinic. And in getting to know her a little bit better, I found out that 2 years prior to her cancer diagnosis, her fiance had unexpectedly committed suicide. And so she was still dealing with the trauma of that and was already in some mental health counseling. And at the point when I met her, she was actually seeing her therapist twice a week. So of course, I strongly encouraged her to continue to go to counseling because now she wasn't only dealing with the fact that she had cancer and the impact that cancer and cancer treatment was having on her life, but she still was working through the grief and loss of a loved one to a very traumatic event. But some other things that we talked about was sleep hygiene. And so giving her some ideas and some strategies about how to help with her sleep. I also talked to her about the connection between sleep and mental health issues and how that can impact someone's level of fatigue. And you'll find that this is a very multidisciplinary approach as we talk today with her. With her financial issues, she wasn't working. She had taken a significant amount of time off of work for her surgery and her treatment. And because of her exhaustion, she wasn't having the energy to go back to work. So financially, she was really struggling to afford her rent, to pay her monthly living expenses. Unfortunately, a lot of the programs that I'm familiar with are things that patients can benefit from while they're in active treatment. She no longer was in active treatment when we saw her. Also, her family, she comes from a family with a lot of strained relationships and friendships. And while she was going through her cancer journey, a lot of family and friends pulled away from her who she thought would be there for her, and they weren't. And so that was another layer that she was dealing with, is the loss of some family members and friends who just weren't there for her when she needed them the most. One other thing I want to bring up, she was very self-conscious of her voice. And I'd never met her before, but for me, her voice sounded okay. But to her, because she was in the entertainment business, she felt like it just didn't sound right. And she was also wearing scarves around her neck to cover her scar. And she just was, she just didn't like her appearance and how she was looking. And so that was another thing too that we talked about, was just her appearance and her body image issues that she was having as well. I encouraged her to learn meditation and some stress management, relaxation to help her with her coping. And I think with that, I'm going to turn it to Maura.
Hi, everybody. I'm Maura Harrigan. I'm the dietitian. And this was really a fascinating case from a nutrition standpoint. But initially, she came in and she was at a good body weight and her weight had been stable. And she was at a BMI of 26. And she reported herself as a lacto-ovo vegetarian. So, on paper, I was like, okay, this is good weight, follows a healthy diet, yet she reports this extreme exhaustion. And it looked like her thyroid management was under control. So I was like, so what's the story here? And then in talking with her, what she'd done was what a lot of cancer survivors do, is she went on to Dr. Google to try to investigate now that her perception is, now that my thyroid is gone, there must be foods my body can't handle. And apparently there are a lot of sites on the internet of people who ascribe to this thinking. And she found them all. And she started eliminating all sorts of healthy foods from her diet because she just thought, oh, my thyroid can't handle these. I don't have a thyroid, therefore my body can't handle these foods. So she kind of went off the rails and was not eating during the day and eliminating all of her, mostly the vegetables that she loved, these nightshade vegetables. So, and the other thing was she ended up not eating during the day, and then in the evening become ravenous and then consume like 90% of her calories at night. All of this was contributing to her fatigue. So, so it had to start with explaining to her what it means to have your thyroid removed, but also to have a replacement medication that takes the place of that and does the job. So there's no need to eliminate foods when you have your thyroid removed and you're stable on medication. Well, that was a revelation and just such a relief to her. And then also the reason why she wasn't eating during the day was because she heard that when you take your thyroid medication, you can't eat for 10 hours. So that's why she would take it in the morning and then not eat all day. And so we had to straighten that out. And really, you just have to standardize what you do, but you can do it with 30 minutes. You know, take the medication, wait 30 minutes. So a lot of, I have a lot of people keep their thyroid medication by their, you know, on their nightstand. And when they wake up, the first thing they do is take their thyroid medication. And by the time they get out of bed, go into, you know, do their thing, 30 minutes have gone by and they can eat breakfast. So it was really kind of straightening out a lot of misinformation and confusion that she had. So we got her taking her thyroid medication at the proper time, eating during the day on a regular schedule. So we shifted her calories the way it should be, distributed throughout her day. We got her back on her lacto-ovo vegetarian regimen. And also, we talked about the importance of creating an overnight fast for her, which, we want a minimum of 12 hours where you stop eating the night before and then when you start eating the next day. So it's just a way of getting people to distribute their calories properly during the day. So she was really a mixed bag of issues, nutrition issues, which is why I think this is such a great case study, because she had all misinformation. Her meal timing was off. She was eliminating foods. She had a misunderstanding of her medications. And once we talked all through that, she was relieved. And that's why she reported that nutrition was, had such a big impact on her for that first visit and reduced her stress. And then when she came back for the second visit, she was a new woman. She was just so happy. So, and she's just a terrific person all around and open to counseling, which is great. So with that being said, I'm going to pass this off to Scott for his discussion.
Great, thanks, Maura. So yeah, and as Jevin was kind of alluding to this when we first started talking about her, you know, again, on paper, you would look at Miss S and you'd say, you know, she's a young survivor, you know, quote unquote, only had the thyroid removed and didn't have the radioactive iodine. So it should be kind of a straightforward case. And as you can already see, before you even get to the physical therapy component, there's a lot of layers here that we had to get through to really know what was going on with her. And from a physical aspect, you know, what was contributing to her fatigue was this change that she had experienced. You know, she had this surgery and now she was on this medication. And prior to her diagnosis, she was somebody who was very active. She was somebody who was going to the gym several times a week, you know, was, you know, in a pretty good routine. Like Maura was saying, like, you know, was eating well, good body weight prior to all of this happening. And then she has this surgery, which really kind of threw her for a loop. And she now presents like a lot of survivors present to us in clinic, which is they don't know what they're supposed to do post cancer, right? Post surgery. How are they supposed to start exercising again safely? You know, they think that all of a sudden everything has changed, and for some of our survivors, that's true. And for her also specifically, she actually did have some range of motion restrictions because of her incision. Her rotation was actually limited. You know, she said that sometimes, like when she was driving, she'd have to rotate her shoulders in order to look over her shoulder, you know, to look at her blind spot while she was driving. So in that first visit, I had to, first of all, I had to kind of give her the space, and allow her to tell me all of this, and then reinforce with her that yes, it's okay to go back to working out, and but this is kind of systematically, we're going to rebuild you back up. We don't expect you to go right back to where you were if you've had this layoff of time, and also talking about safe exercise, right? Like, we're not necessarily sending people to CrossFit. We don't need to be flipping tires and swinging sledgehammers and everything else like that. So to give her permission to say that yes, it's okay to go back to exercising, and then also more specifically, from all of our training as PTs, to assess that limitation in range of motion that she had, and on the spot, I was able to prescribe a home exercise program for her to do some stretching. And so the remarkable thing for us was, after that first visit, where she marked her fatigue on the brief fatigue inventory, which we'll get into in a little bit. It was over 7, so it was high fatigue. And when she came back to us the second time, it was like 3.5. It was literally cut in half. And I look at that and I say, that's yeah, obviously, that's my interpretation of, she's exercising more now. She's got more range of motion now. But obviously, we're only going to reach a certain ceiling with that if the nutrition aspects aren't addressed, if her emotional health isn't addressed, and if her medication isn't properly dosed. So you can see, that's why she is a great example of the multidisciplinary approach, is because we can look at this through our own lens, but we have to realize that there are other components to this person that we can't necessarily have an effect on. And so that's why we need the dietitian and the social worker and the medical component to all kind of come together, so that we can solve her her concerns. So at her second visit, once she was now back into a routine of going back to the gym a little bit, then we were able to get a little bit more specific to say, okay, now we can do some more specific strength training. And so again, was able to come up with a program for her, and be able to give her some of the TheraBands so that she can do some stuff at home, modeling some stuff that she can do at the gym. And then interesting for her, when she came back to us for her third visit earlier this year, she related to me that prior to her diagnosis, as part of being in the entertainment industry, she was also a dancer. And she had felt that her balance was off a little bit, and so she wanted to work on her balance a little bit more, because she wanted to go back to dancing again, kind of getting back to that prior level of function where she was before. So she was actually due to come in to see me for direct PT right before all of these COVID-19 restrictions hit, but hoping to get her back into the clinic sooner, or to get her into my outpatient clinic, so that we can start addressing some higher level balance activities with her. But yeah, so that is Miss S. And that's why we wanted to kind of lead with her with this case for cancer-related fatigue, because like I said, all of us had to come at it from our scope of practice to really make a positive change for her, and to have her feel better. Before we launch into the didactic here, I want to stop here for a second and see if you guys have any questions about Miss S, or kind of in general, like how we approached her. Yes, Kathy.
Kathy, I'm going to unmute you. There you go. Now we can hear you.
So it was Erica that had the question.
Oh, Erica, sorry.
Oh, Erica. Yep. Oh, no.
Hang on, Erica.
Nope, still muted. There you go. Now we should be able to hear you. Oh, no, we still can't. I don't know if anyone else can hear her. No. Erica, it might be an issue with the mic.
Can she type it in the chat?
Yeah, that was, yep, just try to type it in the chat and we can read that.
Okay,
We also
Amy,
have-
Amy, I saw you raise your hand. So as Erica is typing, Amy, what's your question?
Oh, there, we can hear Erica now.
Oh, yeah. It was just very low.
Is that better?
Yes.
Yeah,
A little bit
okay.
closer helped.
I tend to sit far away. Okay, so this individual saw nutrition and PT and counseling. Did that add to her financial concerns? I often see people who decline seeing our survivorship clinician, or who decline to see nutrition because of financial concerns, because of an additional copay. Is that the case with your program, or does everything get bundled where the individual doesn't have a copay for every service that they're getting?
Yeah, so that's a great question, Erica. So fortunately, we do not bill for all four of us. It's billed under the medical oncology provider, being myself or Tara, whoever sees the patient that day. So they're billed for one visit for a 25-minute consult, just like they would be for a routine follow-up.
Mhm. And this particular patient had Medicaid, so she didn't have to pay any copay at all.
Oh, good.
Yeah, and we did. Oh, no, I was just going to say, just to kind of dovetail with that, we talked a little bit about that last week, and obviously that's a big question, for so many of us, and ourselves even included. We at Smilow, we're pretty fortunate that our survivorship clinic helps get funded through charitable organizations. Our cancer hospital has set up a bike ride, and even with the restrictions that are going on right now, they are going to do it as a virtual ride, and so that helps to offset the cost of the 4 providers. So again, we can only, so we only have to charge through the medical oncology provider and not have to charge for the other 3. I know for my department, the rehab department, and I know for the social work department as well, our services are cross-charged to the cancer hospital, and the Closer to Free fund helps pick that up.
And just for me, as the social worker, even throughout the system, any patient that I meet with, it's free of charge. It's not, they don't have to pay a copay at all within the whole context of the cancer center.
That's good. Do you mind if I ask one more question? It's just a yes or no.
Yeah, go ahead.
Okay. Do you prescribe aerobic exercise kind of, I don't want to say standard, nothing is really standard with PT treatment, generally speaking, but is aerobic exercise always a part of your program with a person, an oncology patient?
Yeah, absolutely. I mean, that's usually where I start. I use the aerobic exercise as kind of the building blocks, and then kind of getting more specific after that. And that's really the nuanced part of what we do in the survivorship clinic, all of us really, is to take these national guidelines that we have within our profession and distill it down and individualize it to the person who's sitting in front of us. So again, like I've been going off the American College of Sports Medicine recommendations for cancer survivors as far as the amount of cardiovascular exercise that they should be doing, and the amount of strength training that they should be doing. And those recommendations got updated in the fall, which was really, really exciting. We're actually going to talk about that in a minute. But then, and really the nuanced part of it is, again, how do you take those recommendations, those national recommendations, and make it personalized to the person who's sitting in front of you to figure out what is their preferred method of exercising, what's motivating to that person, what can we do to help them with goal setting and that sort of thing. So yeah, that. And then again, because, usually prior to all of this. The person is in front of me. If I have to do a range of motion assessment, or I can do a strength assessment, I'll even do a balance assessment if somebody has peripheral neuropathy, if they report peripheral neuropathy. So I can really then make a program that's a lot very much individualized for them. Like I can print out the exercises right then and there. And then within our network, if it's somebody who I think needs lymphedema, a lymphedema assessment, I will, Jevin and I will communicate, and we'll make sure that that person is referred to a lymphedema therapist, either in our network if they live close by, or if they live in other parts of the state. Then it's my responsibility to reach out to the different lymphedema therapists that are in the state to say, oh, if you live up, in the Hartford area, then I want you to go see this person over here. Because I'm not going to make that person drive, 50 minutes one way for a session. So that's a very long-winded answer to your question. But yes, I always start with aerobic and then use that as my jumping off point to make it more individualized.
Okay.
All right, Amy, I know that you had raised your hand.
Yeah, hi everyone. I'm from Ohio State. I work at the James. Thanks for having me. I think it's a testament that she wanted to come back and continue to see you guys session after session. And now for the neuropathy imbalance with you, Scott, I think that's great. I did have two questions. The first question is if you guys did any scar management with her, and if so, what did you do? And then my second question is leaving my head. So we'll just start with the first question.
Sure. So yeah, so I did in that first visit, Amy, I did give her, I showed her how to do range of motion exercises for rotation, and I did teach her how to do a little bit of self massage as well. If she was somebody who had extensive scar tissue or extensive soft tissue concerns that needed more hands-on mobilization, then that would definitely generate a referral for outpatient PT or OT. And again, based on where that person lives, if they live close to one of our network sites, then I would send them to one of our therapists. If it's somebody that lives a little bit further away, then we'll do an external referral so that person can take that referral to a provider that's closer to them. So that is one of the challenges in a 30-minute visit. You have to get a lot done in a short amount of time. And so then we have to realize that we may have to refer out if we're not able to provide all of that care at that particular moment. So yeah, for her, I did teach her how to do some of that scar mobilization on her own, as well as some range of motion exercises.
Yeah, I understand the triage component, to those visits, because you're right, like 30 minutes, you're just an eval in 30 minutes, let alone get to education and exercise. It's a lot to cover. We do that with our geriatric oncology clinic. I remember my second question. So I noted that, in the handout, it said that she saw you guys 9 months post-diagnosis or post-surgery.
Yeah, post-surgery, yeah.
Yeah. I'm wondering if, I guess this is kind of more of an open conversation with everyone. I know with these patients, we struggle to see them earlier than what we would like to. And to your point regarding like the driving, she's then developed this behavior of not turning her head. And I'm just wondering if you or anybody else has any like different strategies on how to better educate our docs to get these head and neck surgical patients to be seen earlier in the outpatient setting. I mean, I'm on the same floor as the head and neck docs, and we see patients earlier, but it's still not early enough, I feel like.
Mm-hmm.
And I'm just wondering if like your surgeons, do they do any education regarding like, don't move your neck for however long, or if they give those patients any restrictions for you guys?
Yeah, that's a great point, Amy. And it's honestly, it's something that we have, we keep asking ourselves that question, and we've asked ourselves that question since we started in 2006. I know that, and Jevin and Dr. Samp, you guys can jump in here if you want. I know for, we started something in the breast oncology team where we're actually trying to get those referrals triggered earlier so that that way we capture those patients sooner. So you know, to your point, that we're not waiting 9 months, a year, 18 months before we're seeing those patients. Jevin, Dr. Samp, did you want to talk about that really quickly?
Yeah, actually, Sherry Storms, who's on the line, helped us initiate this pilot program that now is standard of care in the breast center, where every new patient gets a referral to survivorship in breast, early stage. And, you know, it makes Kiki's referral list very long, but she then goes through and invites them for a survivorship visit basically as soon as they're done with their active treatment. And then, you know, not including endocrine therapy or maintenance Herceptin. From the thyroid standpoint, we actually have a champion nurse in the thyroid clinic who would refer every single patient at the post-op visit. So I think probably this patient was referred earlier, but patients decide when they're okay with missing work again, and when they're, you know, I don't want to come over this summer when my kids are not in school, and yada yada. And so I think there were some factors like that that put her out that many months from her diagnosis.
Thank you.
Oh, great questions.
Hey, I'm going to interrupt here since I'm the official timekeeper. So we do have a didactic to do, and we're about 10 minutes late into starting it. So it's a 15-minute. So, I mean, I think we'd like to go through the didactic, but I'm just going to challenge the team to keep it brief. And you know who I'm talking to. So that's right. Jevin's raising his hand. So that guy. So, and we did leave time for after the didactic for more questions, but I think we want to get some points across. All right. But it's, you know, I love hearing all these great questions. But anyway, so why don't we start the didactic?
Yeah, so I'll pull up the didactic here. Scott, I'm going to give it over to you, and then we'll go from there.
Okay, great, thank you. So just to quickly go over the definition of what cancer-related fatigue is. Most of you probably know what this looks like if you've been treating it for a while, but we go off the National Comprehensive Cancer Network's definition of what it is. And I think the important points here is that it's the most frequently reported physical symptom that our survivors report during and after treatment. It can affect up to 70 to 80% of our survivors, and I would argue probably 100% of our survivors at any given point during their cancer trajectory. And it's fatigue that is more distressing and is not alleviated by rest. It's not related to exertion, and it's not relieved by rest. And so that's what sets it apart from regular fatigue. And so, you know, the question is, you know, kind of physiologically, you know, what causes cancer-related fatigue? And, you know, we could spend, you know, the next 2 hours talking about, you know, all the different ways that all these different insults to the body, so to speak, affect the body and make it more fatigued with all the treatments that our patients experience. But I think this next graphic, this next slide, it really sums it up for me. And this slide is actually from the Academy of Oncologic Physical Therapy. I think it's a great visual to show how, you know, the pulmonary system becomes affected, how the cardiac system becomes affected, the vascular system becomes affected, and skeletal muscle can be affected based on the treatments that our patients are getting. So you put it together, and it's kind of this multiple hit theory, or kind of really, you know, the perfect storm, so to speak, that it all kind of comes together and it truly hits our patients. And that's what's really causing the fatigue, is that it's not just one system that's being affected, but it's multiple body systems that are being affected by treatment. And as you can imagine, if somebody is chronically fatigued, obviously it's going to impact their physical function, but it's also going to affect their mood, how they perform at work, how they perform at home, and then their own self-worth, and feeling like, I don't feel like I'm being productive at work. I don't feel like I'm being productive to my family. And so it kind of becomes this vicious cycle, right? And so that's where we have to step in, all of us as healthcare providers, to kind of break that cycle of fatigue for our patients. And so I alluded to this a few minutes ago, and I got really excited when the new American College of Sports Medicine recommendations came out in the fall, kind of this international think tank from around the world, the APTA, American College of Sports Medicine, Canadian Physical Therapy Association, Australian Physical Therapy Association. They all got together and they updated the 2010 recommendations for cancer survivors, because in 2010, those recommendations that came out for cancer survivors was really based on what they were recommending for the general population, which was the 150 minutes a week of cardiovascular exercise. And strength training once or twice a week would be nice, but they weren't really succinct about it. But when this international group got together and updated these guidelines, and they were released last year, it was a lot more definitive. And actually, we're gonna see this over the next couple of sessions, how they were able to really hone in on symptoms of cancer and be able to provide a specific dose of exercise, a specific dose of rehab for different conditions that our patients are experiencing. So for cancer-related fatigue, they are definitively saying now that our patients should be getting at least 30 minutes of cardiovascular exercise 3 times a week. And they should also be doing strength training twice a week, a minimum of 2 sets of 12 to 15 repetitions. And I don't want to get ahead of myself here, but when we talk about fear of recurrence and how that can relate to cancer-related anxiety and depression, there are specific doses of exercise for those conditions as well. And so that's what's really exciting about this, is that we can really target our intervention based on how our patients are presenting to us. And then again, how do we assess that, especially in the survivorship clinic? As Amy was saying, like 30 minutes, you're right. It's a real quick get to know you evaluation and put together a plan all in a short amount of time. So we've been using the brief fatigue inventory that MD Anderson developed. That's also been vetted by the American College, or the Academy of Oncologic Physical Therapy, rather. Their EDGE task force recommends using the brief fatigue inventory. So that's good for those of us that are PTs. They also recommend the cancer-related fatigue distress scale, which is 20 items versus the brief fatigue inventory, which is only 9. So it's a little bit quicker to fill out. Or just using a good old-fashioned 10-point rating scale, 0 to 10, what's your fatigue, will work also. I will tell the PTs in the group quickly that the Academy of Oncologic Physical Therapy is actually currently revising their clinical practice guidelines for cancer-related fatigue. It's currently in review for publication now. So stay tuned, because those new CPGs should be coming out later this fall. And then lastly, again, talking about meeting the patient where they are, taking these national guidelines and distilling it down and making it personal to the patient. Again, talking with them about how do you track your exercise, whether it's, electronically on our wrists or on our phones, or old school, just writing it down, exercising with a friend or a coworker. And of course, right now trying to be mindful of social distancing while we exercise, but we can still exercise 6 feet apart from each other at this point, setting specific goals, I know a lot of the road races have been canceled or postponed, but even doing something like an active vacation at this point might be something to help with goal setting. And then again, I will tell people, these are some of the strategies that I will use personally. When you personalize it, our patients oftentimes buy into it a lot better that way. All right, and then I'm going to ask Jevin to jump in here now.
All right, thanks, Scott. I'm hearing an echo again. Let me just get back here. Okay, sorry about that, everyone. Want to make sure not causing anyone's ears to hurt. So again, I'm Jevin, the PA with the Survivorship Clinic. When I think about cancer-related fatigue, first of all, it's definitely in the majority of survivors we see coming through. And first I think about what are some of the highlights, what are some of the questions I want to be asking this person? How long has it been going on for, and how long has it been since your active treatment that you had, and then considering what systems those treatments could be affecting, sort of alluding to what Scott mentioned before, and that great graphic he showed in the different body systems. Is this affecting their heart in any way, their lungs, or their musculoskeletal system, things like that? How is it interfering with their daily life? Is this affecting their activities of daily living? Is it affecting their ability to self-care? And is it persistent despite getting still a good night's sleep? As Scott mentioned with the definition, it's not the type of fatigue that gets better with rest because of how it affects the body. And is there an emotional component to it? I'll let Angela get into a little bit of that soon here, but we got to consider fatigue as multifactorial. There can be the physical component and there can be the emotional component. Going back to that multifactorial, consideration, there are also a number of other comorbidities and medications that can be considered here too. Some of those other conditions can be thyroid-related conditions, even aside from a history of a thyroid cancer that we talked about, any cardiovascular health issues, pulmonary issues like COPD, for example, any adrenal issues, mental health-related concerns. And then, of course, thinking about the diagnostic testing and workup that can be done to assess for all of that, whether it's blood work, a sleep study, for example, if there's sleep-related issues, and so on. So medications that can also lead to cancer-related fatigue can be things like antiemetics. Are they on opioids? And considering alternatives for, whether it's like pain or nausea and vomiting, for example, is important. And on the right, I list an article that goes through some of these medications that can cause chronic fatigue. So I think it's important to be considering that in the workup as well. And then, of course, looking for any suspicious signs or symptoms of metastatic disease. So again, from the medical oncology side of things, I'm always looking to see, okay, are they having any unintentional weight loss? Is fatigue persistent or getting worse? Are they having any unusual bleeding anywhere? Any new swollen lymph nodes or masses that they might have noted anywhere? And any new recent fever or chills that are persistent or not getting better. These are all just a few at least of the signs and symptoms that I look for when thinking about metastatic disease. And so next, I'm going to turn it over to Maura.
Thank you. You can advance the slide. Oh, thank you. So again, from the dietitian standpoint, fatigue can manifest many different ways in terms of how people are eating. But the bottom line is our goal is we really want to stabilize blood glucose levels. That's the body's fuel. So we want to look at ways that that can be interrupted or adversely affected. So one is just simple meal timing. And we saw that with the case study. She was not eating during the day and she was consuming the bulk of her calories at night. So she was mismatching her fueling with her activity. And that's where creating the overnight fast is helpful to kind of straighten that out for people. I'd like to have a minimum of 12 hours. Ideally, you can stretch it to 16. So straightening out meal timing. So that's where how you eat is just as important as what you eat. Now, in terms of what you eat, I'll do a diet history and I look at the macronutrient fuel mix. So like how much protein are they eating, how much fat, how much complex carbohydrate, and try to straighten that out. A lot of times I find cancer survivors come in with a very high, simple carbohydrate intake. And that could be contributing to their fatigue. So it's kind of straightening out that macronutrient mix. And mostly it's adding complex carbohydrates, which means you're adding fiber. And also you're decreasing the added sugars. And that's kind of a result of shifting around the fuel mix. But again, if someone's fatigued, you have to make it doable, just like Scott was talking about. I have to have them leaving saying, oh, I can do this. So I have to make it easy, simple ways for them to eat well, because they're tired. So try not to make it harder. Okay, so now I'm going to pass it on to Angela, and we have about 6 minutes left.
Okay. Hi, everyone. Angela with social work. Next. Whoops. Can you go back? Thank you. Okay, so when I meet with survivors, something that I like to talk to them about is that with cancer-related fatigue, it's not just physical, but it's also dealing with the stressors, the emotional stressors of cancer and cancer treatment. And with cancer-related fatigue, it can have a negative impact on work and social relationships and mood and activities of daily living. Scott touched on some of this. Fatigue is not only a symptom of cancer and cancer treatment, but as we also know, it's a symptom of depression and anxiety and even stress. Cancer-related fatigue can cause sleep disturbances, and fatigue can persist even when patients report adequate sleep. Next slide. So these are some of the risk factors for the development of cancer-related fatigue. If the survivor has a history of mental illness, including depression and anxiety, they've had sleep disturbances prior to or during treatment, physical inactivity, a tendency to catastrophize, or somebody who has really a negative outlook or negative statements about fatigue, or just even life in general, exposure to childhood stress, including abuse and neglect, as well as loneliness, particularly with older adults. Next slide. And so with that, thank you.
Okay, so just wanted to open it up to everyone here now. If anyone has any, questions or comments, maybe some stories to share from their own clinic about, survivors or patients they've seen. Kathy, go ahead. Go ahead and unmute yourself if you can.
Thank you.
Perfect.
I was just curious, how many patients do you see at your clinic days?
We have up to 8 patients that we see in our clinic on the days of clinic. Again, they're 2-hour visits where they're meeting with each of us for 30 minutes one-on-one. And so we're able to fit that many in just because of that elongated appointment time. But again, the benefit of it is that because we're a multidisciplinary team, it's great for survivors who need more of that complex care with those concerns that can be addressed by each of the different providers in our clinic. And that with these concerns, they often lend themselves well to each of the 4 of us. And then it's sort of like one-stop shopping. They don't need the referrals. They don't need separate billing or anything like that for the appointment. Great question, Kathy. Others? And then also feel free, if you're camera shy or audio shy, you can type in the chat too. Oh, Elizabeth, yes, go ahead. Feel free to unmute yourself.
Can you talk to us about how you do your documentation? Does everything land within the context of OneNote? And then Javin, are you responsible for doing all of the referrals? And like, I'm curious about like your real-time interaction within the context of seeing one patient. And because I know you do huddle in the morning, do you huddle on all 8 patients in the morning, or just kind of talk about the operational stuff? Thanks.
Yeah. So, you know, typically we'll spend about anywhere, depending on the number of patients in our clinic that day, we'll spend anywhere from a half hour to an hour huddling in the morning, reviewing the survivorship care plans, and reviewing our plans to discuss with the patient that day, depending on their concerns they're coming in with. And then after the clinic, we like to debrief and discuss the survivors we've seen that day as well. It's really to our benefit to be able to, you know, bounce off of each other how our visits went and talk about any referrals that might be needed. For example, if Scott is seeing someone and they need referral for outpatient physical therapy, you know, I'm able to place that. Or if they need any referrals from when I see them for, say, genetic counseling, or to the sexuality, intimacy, and menopause clinic we have, I can place that as well. And yes, for the most part, I'm the one placing the referrals for any outpatient services they need. Besides that, a number of resources are provided, though, by Scott, Maura, and Angela during their visits. And we actually also give the patient a folder that they can take with them with additional resources as well. For example, our integrated medicine program. As far as the note template, I do have a template that I use. It highlights their brief oncology history, goes into their top concerns for that day, and then just a summary saying that we've reviewed the treatment summary and survivorship care plan, what potential late effects we've discussed based on their cancer history that day, and then any follow-up plans following that.
Yeah, and to go off of that, so our documentation, what I do and what Maura does is like we write our notes, and our notes get attached to Jevin's note. And I'm basically writing like almost like a narrative, almost like an old school SOAP note. You know, what was the patient's, you know, concerns and any objective things that I found, you know, an assessment, and then what's the plan moving forward. It's kind of a free flowing didactic rather than spot by spot kind of fill in the flow sheet kind of a thing, or flow chart kind of a thing. And so our two notes get attached to Jevin's note. Angela has a specific questionnaire that she has to fill out through the Department of Social Work. So she has her assessment that she fills out, but it all falls under, you'll see it all fall under the same date, obviously. So if you go through the patient's EMR, you'll see all four of our notes in that patient's EMR, you know, and you're able to, you know, if a provider can click on it to see, oh, well, what did Maura recommend? What did Angela recommend? And what did Scott recommend for this patient when they came through the survivorship clinic? Any other questions? This has been great. We've had some great dialogue today. I do want to be mindful of the time. It's 4 o'clock on the East Coast. And so I would say that if you have any, you know, if a question hits you later on, please feel free to reach out to us. Jevin, again, the email is?
It's survivorshipecho@yale.edu. I will put that also in the chat here again.
Great. We will meet again in 2 weeks at 3 o'clock East Coast time. So we're looking forward to seeing all of you guys then. I will leave everybody with this. This Sunday is National Cancer Survivors Day, and we kind of did this a little bit with our initial icebreaker, asking everybody what kind of brought them to this survivorship echo. But I would ask all of you to kind of reflect this weekend on what survivorship means to you. You know, to think about, you know, why are you here, and why do you do what you do? And for those of us who are survivors, to realize that every day for us is Cancer Survivors Day, and we thank you for everything that you do for survivors across the country.
All right, thanks everyone for jumping in with us today. It was great seeing all of you. Great participation. I will send out the email and the post-session survey if you could get that back to us. And we look forward to seeing you next time in 2 weeks. Enjoy some of that beautiful weather out there. Bye, everybody.
All right.
Bye.
Take care, everybody.